It's my pleasure to introduce Monica Kraft. She's been a good friend and a professional colleague of mine for now over, a couple of decades, Monica. She's a national and international leader in asthma research and translational medicine. And now she's also the Robert and Irene Flinn Professor of Medicine and Chair of Medicine at the University of Arizona. She did her training early in California at Davis, then UCSF, some internal medicine at UCLA. Then she went to Colorado, to Denver, where she did her training in pulmonary critical care medicine there at National Jewish. She worked with Richard Martin, and early in her career looked at atypical infections in asthma and nocturnal asthma. And I'm not sure if we see a lot of pulmonary fellows back there, but it involved bronchoscopy and those related kinds of things. So she'd do that at 4 p.m., which is fine. We used to bronch at 4 in the afternoon, but also 4 a.m. So she'd get up and do it early in the morning as well. After a stellar career there, she went to Duke, where she headed the asthma program, was pulmonary chief there as well, and 5 years ago moved to the University of Arizona as chairman of medicine. And she has not only a very distinguished academic career, but now she's had the opportunity to look at the integration of Banner Health with the university there. So she has some lessons for us as we go forward with Atrium here. So she's, again, well known in the area. She's a past president of the American Thoracic Society, got their Distinguished Achievement Award. And now she's going to talk to us about mechanisms to precision medicine in asthma. That's part of an initiative that the NIH has called the PRECISE Network. She's a PI of that. We here are a member of her site, as it were, as a consortium. Wendy Moore leads that effort. But we've been involved together, both at Duke through AsthmaNet, which I was a PI of, and this. So please welcome Monica.
Well, thank you, Steve. That was a really nice introduction. It's great to be here. Thank you. All right, I think we're ready to go. All right. Well, I really appreciate the opportunity to talk a little bit about asthma and where we are right now in the field. And I have to say, it's an exciting time to be in the field because we've really learned a lot, and I'll explain where we're going. So a few disclosures. So what I hope to talk about today in the next 45 minutes or so, I'll talk a little bit about some advances in asthma pathobiology. You know, that's a topic all to itself. So I'm going to just do a few snippets and talk a bit about some of the translational work that we're doing at the University of Arizona. Talk about how to employ some biomarker or precision approaches to the diagnosis and treatment of asthma, and how that really helps us decide who should get the best treatment, for the right patient. So I'm going to start with a case. So this is a 38-year-old female who has severe persistent asthma on chronic oral steroid therapy, who presented with increasing shortness of breath and wheezing. She's had a long history of asthma, diagnosed as a child, and really had required 1 hospitalization per year since her diagnosis. This is actually one of my former patients. She'd been intubated once, been on oral corticosteroids intermittently, and has a lot of the comorbid conditions you would expect to see in a patient with severe asthma: reflux, allergic rhinitis, has a history of nasal polyps, depression, and osteopenia. She has daily symptoms of shortness of breath when she's not having an exacerbation, limited activity, despite our best efforts using rescue inhalers 4 to 5 times a day, and she is adherent with her medical regimen to the best that I can tell, and I actually really thought she was. And of course, adherence is a whole another topic that's really important in the management of chronic disease. So her problem list is what you see here. And allergy, she also has aspirin, causes rash and wheezing, so she has what we call Samter's triad, which is asthma, aspirin sensitivity, and nasal polyps. And then her medications, she came on methylprednisolone to the ED, not always on that dose, it varies. She's on high-dose fluticasone salmeterol, montelukast, beta agonists, omeprazole, loratadine is an antihistamine, fluticasone nasal spray, and then a few other medications for her bones. She's married with 3 children, 2 dogs, outside cats, office work with no exposures, and she's actually a never smoker. She's not smoking. She has a significant family history of asthma in her mother and atopic dermatitis as well. And on physical exam, she exhibited prolonged expiratory phase with moderate air movement, diffuse expiratory wheezing. And on some biomarker evaluations, she had elevated peripheral eosinophils at 350 and a high exhaled nitric oxide at 40 parts per billion. The normal is less than 20. So suggestive of some untreated inflammation despite all that methylprednisolone. And so this is her chest X-ray, and I think you can kind of appreciate she's got some flattened hemidiaphragms, no obvious infiltrate, heart size is normal, and otherwise unremarkable. And these are her lung function tests. We were able to get those on this day. So looking at her forced vital capacity, you can appreciate almost normal at 78% predicted. But what is quite remarkable is her FEV1, her forced expiratory volume in 1 second, which is 48% predicted. And normally this should be about 80% or so. You should be able to get about 80% of your exhaled breath out in the first second. So that leads to the significantly reduced ratio, which we consider consistent with significant airflow limitation. What's also remarkable is this FEF 2575, of which not everyone believes in that one, but it suggests that this is the forced expiratory flow from 1/4 to 3/4 of expiration, and you'll notice how significantly reduced that is. So it's suggesting perhaps there's a small airway component to her asthma, although we'd want to verify that later with lung volumes and other ways of looking at small airways. But a very remarkable set of pulmonary function tests. So we'll get back to her and what we can do for her. So what is asthma? Well, it's a syndrome, chronic disease manifested by cough, wheezing, and shortness of breath. And really the big issue is this reversible airflow obstruction, meaning that if a patient receives an albuterol, a beta agonist, they can see some improvement in their lung function. And that is not necessarily specific to asthma, but it is one of the features most of the time. Sometimes in the setting of severe asthma, you don't see as much reversibility. And then this concept of bronchial hyperresponsiveness, which is this airway twitchiness. So I know there's probably some people in the audience who have asthma, so let's say on a colder day or in the spring, walk outside, take a breath, inhale some of that, the pollen that in North Carolina is a sight to behold in the spring, coating the cars, and developing wheezing, cough, and shortness of breath. And that is this airway twitchiness, this bronchial hyperresponsiveness. And that's in part driven by airway inflammation, and that's been the topic or the focus of a lot of research over the last few decades. So this is just a little cartoon really showing why asthma makes it hard to breathe. And you can see that on the setting of an asthmatic airway, there are a lot of structural changes that go on. There's more smooth muscle than there should be. The focus of some work that I've been involved with for a while now is the airway epithelium that sort of lines the airway and its dysfunction, especially mucus secretion. And when you think about mucus, you might think more about COPD or bronchiectasis, cystic fibrosis, but mucus is quite relevant in asthma as well, especially in the setting of a severe exacerbation. And unfortunately, this is why patients may die in that setting because they simply can't ventilate because their airways are filled with this mucus. So a lot of really important and relevant changes that go on in the asthmatic airway. So I was telling you that I thought this was a great time to be in the field, and one of the reasons is there's been this explosion on the immunology side. I think we have a much better understanding of some of the pathways relevant to asthma. I wouldn't say we have it all figured out, so I guess that's job security, right? There's still work to do. But it has resulted in the development of specific therapies that target certain cytokine pathways, biologics. And that has made that has really allowed us to offer therapies beyond inhaled steroids and long-acting beta agonists, and I'll talk a little bit about those later. We've moved into this phenotype, which are a collection of clinical characteristics. How do we phenotype patients in the clinical arena and really look for the underlying mechanisms driving those phenotypes, which we call endotypes? And I'll talk a bit about that, so the field is changing that way. Certainly there's been some interesting work on airway structural changes and remodeling and why the airway in asthma changes permanently. And then one of the areas I've been involved in for a while is in this whole area of innate immune dysfunction. So we have adaptive immunity, which is really the allergic response you can think of. And innate is more the host response. And we found some very interesting changes that are going on in asthma with regards to the innate immune system as well. And so I wanted to talk a little bit about that. This is some work that we've been doing with surfactant protein A. Surfactant protein is made in the lung. It's also it's made by alveolar type 2 cells, club cells, mucosal cells. It's in the sinuses, although that's a little controversial, and in the gut, really on mucosal surfaces. And I want to just give a shout out to my good friend and colleague, Julie Ledford. She and I have recently formed a company because we've discovered that the surfactant protein A is dysfunctional in some types of asthma, and we're moving towards developing a therapeutic that I'd like to tell you about. So as I mentioned, when you think of surfactant, you might think of its surface tension reducing properties, and those are really performed by surfactant proteins B, C, and lipids. The surfactant proteins A and D are well known for their host defense properties, and I'm going to hopefully at least get you thinking about the fact that SPA in particular has anti-inflammatory properties relevant to asthma. And in general, SPA and asthma have not been linked in the past, and that's been the focus of some of the work we've been doing in the laboratory. And I like to think it's a very beautiful protein. It looks like a bouquet of flowers. It's an octadecamer, and it becomes an octadecamer due to these trimers, which are then formed from monomers. And if we look at the structure of the monomer, that's where it gets relevant to what we're talking about today. There are these different domains that are important for its function. For instance, this collagen domain is responsible for receptor binding, oligomerization. And we've become quite interested in the lectin domain, which you can see is, if we go back, it's going to be in this part of the protein over here. And it's responsible for carbohydrate, pathogen, and lipid recognition. And so we have our big global hypothesis is really that an adequate pool of functional SPA is really needed for normal lung function. And in cases where there's low SPA in the setting of obese asthma that we have published on, or dysfunctional SPA, which has a genetic heterogeneity, genetic components to this, we think that contributes to this asthma phenotype. So I'll tell you where we are with this. So we know that SPA is has an innate immune function critical to preventing asthma attacks. It's produced by the lung. And what we've shown is SPA is made up of two peptides, SPA1 and 2. And we've gone through and sequenced the two genes, and we have found that a specific polymorphism in SPA2 actually results in an SPA protein that is defective in asthma, and that's the first reference that you'll see on your reference list. And we also saw a reduction of overall SPA in the lung in patients who are obese and who have asthma, and that reduction correlates with lung function and asthma status. So we propose that the replacement of a defective or absent full-length SPA with a 10 to 20 amino acid peptide restores the function of the full protein and represents a new class of therapeutic. So we have data, and I'm going to show you that SPA2 reduces airway hyperresponsiveness, and that's that airway twitchiness I was telling you about, in a preclinical mouse model of asthma. And these are, when we look at mouse models, we look at house dust mite challenged mice as well as ova, and we also have an interleukin-13 model of a mouse model that helps us really look at the effects of this protein in a whole organism. And then we also have strong evidence to support that this protective activity is due to a direct interaction with eosinophils, a very important inflammatory cell in asthma, and epithelial cells, which line the airway to inhibit mucin production. So I'll only show you a little bit of data today because I want to get into some other aspects of asthma pathobiology, but these are data looking at a SPA knockout mouse. So this is an SPA mouse that is deficient in SPA and challenged with house dust, and then rescued, if you will, with this peptide, this SPA peptide. And what you can appreciate, so this is methacholine, and so as you give a mouse, and a human as well, humans undergo methacholine challenges, it causes bronchoconstriction. And in this case, we're looking at airways resistance. And so this is the airways resistance with vehicle, and this is what happens when we give the peptide. You can see a nice reduction in airways resistance, and this is looking at large and small airways resistance. So this was exciting to us, and we think this is probably due to some effects on mucin secretion and eosinophils. And so these are data also from a mouse challenged with house dust mite, looking at rescuing that mouse with a peptide that spans this lectin domain. So the polymorphism itself is located in the lectin domain of SPA2, position 223, and we know that this position there's a substitution of a glutamine for a lysine. And so therefore we can show that in fact the eosinophil counts in the mouse lung are decreased, and the mucin secretion is decreased when we give this peptide. Of course, we're not all mice. We need to look at our human model, and we've been looking at airway epithelial cell culture for a long time at air-liquid interface. And so what we can do is we can perform bronchoscopy, we can take these cells to the lab, and they grow and differentiate, and they look a lot like the cells we see in the lung. And so in this case, what we did is we exposed those cells to interleukin-13 and saw this very significant increase in mucin protein message. When we expose those cells to the full-length protein and different versions of the peptide that just spans that lectin domain of SPA2, you can see this nice attenuation of MUC5AC. And in fact, we're moving ahead with this version of the 10 amino acid peptide right here. So I realize this is a whole topic. I could have taken the whole hour, which I didn't want to do, but just give you a little snippet of some things we're working on. And so why is SPA replacement novel? Well, we have shown it's dysfunctional in asthma, and it really has to do with this polymorphism. Those patients who exhibit the polymorphism have more in the way of airway eosinophils and blood eosinophils. That in fact, it appears to modulate this type 2 or this allergic inflammation, the most common asthma phenotype. The efficacy of the peptide spanning that lectin domain appears as efficacious as the full-length protein for readouts that we consider important in asthma. And it can be delivered via an inhaled route to achieve relatively high concentrations because it's so small, and that's some work in progress. It's an endogenous protein, so reducing the likelihood of toxicity. Although what we are doing now is we're working with a medicinal chemist to tweak those little peptides so that they have a more staying power in the lung, because of course we know peptides are subject to degradation in the very oxidative environment of the lung. And that's work that we're doing as part of a small business grant. And then we like to think it may have benefit in patients with asthma who are obese, as we have shown a deficiency of SPA in this phenotype. All right, so now I want to move on to a more clinical aspect of asthma, and where are we now in taking care of these patients? I'd like to think that one day maybe the SPA peptide might be on this list, but not for the time being. And if we think about asthma, there's a number of characteristics. We think about exacerbations, symptoms, lung function, age of onset, gender, body mass index, lots of different characteristics that lead to these different kinds of asthma we call phenotypes, with the goal really of understanding mechanisms to guide therapy for a more personalized precision approach. That's why we're all in this. And this is not unique to asthma. This is certainly something that we're doing in a lot of chronic disease management, and oncology, I would say, has been ahead of the game for a while, and now we're catching up. So this concept of phenotype that I mentioned earlier is they're observable properties of an organism produced by interactions of the genotype with environment, really. So it's a collection of clinical characteristics or triggers. They may, but they may not always suggest a mechanism. And the endotype is the biologic pathway that explains the observable properties of the phenotype. So what the goal is to try to understand what kind of asthma a patient might have, what phenotype do they have, because there's all different kinds. It's not a one-size-fits-all situation. And then endotype is what's the pathway driving that asthma, and therefore can we provide a therapy that targets that endotype. Now I will say, for mild to moderate asthma, I think our guidelines work well for the most part. I think that there even is some heterogeneity in inhaled steroid response, even in the mild to moderate asthma, that I'm not going to talk about as much today. But in general, the guidelines are a great start. When you move to the more severe asthma, and I'm talking about those patients who require high-dose inhaled steroids, a long-acting beta agonist, often another medication, have exacerbations needing prednisone, hospitalized, end up in the emergency department, that type of asthma is really beyond the guidelines, and that's where a lot of this phenoendotyping is especially pertinent. Although I say I still do this even in my mild to moderate patients as well. And so this is a review from Sally Wenzel that I've adapted the figure a little bit just to give you a flavor of what I mean by phenotypes. So right now we put them in these sort of two buckets. This is one way of thinking about it. I'm going to give you another way of thinking about it in just a minute. This is type 2 asthma. So this is, if you think about eosinophils, allergy, that's what's included in type 2. And then we have this non-type 2, which is really where I think a lot of unmet need exists right now in asthma, understanding that type of asthma. But under the type 2 umbrella, we have allergic asthma, this early onset asthma that many of you may be familiar with. But there's also other types of asthma under this umbrella. There is aspirin-exacerbated respiratory disease, like our patient. She had evidence of aspirin sensitivity and nasal polyps. We have a couple of late onset type of asthma, especially in women. It can be very eosinophilic, not a lot of allergy. Then there's exercise-induced asthma down here, which in fact exercise can exacerbate all kinds of asthma, but it can be its own phenotype. I get a lot of referrals for athletes, for instance, where exercise-induced symptoms is a really major component to their disease. Now if we move over to the non-T2 bucket, you'll notice obesity is sort of straddling the two. So obesity can make especially allergic asthma worse, but it can also produce its own phenotype is one of the thoughts we have. And we're seeing these later onset asthma very commonly in women who are obese, have metabolic syndrome, and may in fact, interleukin-6 may be a very important cytokine for that phenotype, and we're going to examine that in our precise network that I'll tell you about later. There's also other types of asthma over here that we understand less about. Of course, there's the smoking-induced. About 20% of asthmatics smoke in this country. It's certainly higher in Europe and Asia. There's also a kind of asthma that really doesn't have a lot of inflammation. We call that polygranulocytic. And so trying to understand maybe if those are the candidates for bronchial thermoplasty, that was something we were talking about earlier. Pollutants and exposures. You know, I live in Arizona, and in Phoenix is number 5 for ground level ozone and number 23 in the country for particulates. And I have patients who live in Phoenix that can't leave their home in the summer because of these environmental insults. And then there's a whole group that has an infection and then develops an asthma-like disease, of which we're still trying to put together the mechanisms for that. So this is just an idea of different kinds of asthma. And that these are, so this slide is to remind me to tell you that multiple endotypes drive asthma phenotypes. So here's an example. So this is exacerbation-prone asthma here. So that could be driven by allergic asthma, aspirin-sensitive asthma, late onset eosinophilic asthma, even premenstrual asthma. So it's a challenging field in trying to determine the endotypes, because sometimes the phenotypes can actually span different endotypes. So our charge as clinicians is how can we use our available tools to figure out what kind of asthma our patients have. So I wanted to show these slides. I want to give a shout out to the group here. You know, you have a gem of a group here working in asthma. I want you to make sure you know that. They've been involved with the Severe Asthma Research Program for many years. This is Wendy Moore, who you heard about, Steve Peters, Victor Ortega, Annette Hasty back there. They've been working to longitudinally follow a group of patients with severe asthma really since the early 2000s. And the good news is that the next iteration of SARP, there have been 3 versions. The next iteration was just funded, so this will continue, which is fantastic news. And so they've been looking at asthma from a cluster analysis perspective and looking at how to group patients based on characteristics, and they have identified these particular clusters based on age of onset, as well as presence of allergy and FEV1 and comorbid conditions. And so you can appreciate that these clusters have slightly different characteristics, and the more severe groups are going to be clusters 3, 4, and 5, are going to tend to be the most severe. And so they've been very successful in really identifying that these clusters exist, and they're actually they're relatively stable over time. And so these are the more severe. All right, and then now they've, especially Wendy has been at the helm with others to look at a new analysis in the 3rd iteration of SARP. How do these 3 clusters of severe asthma, how do they fare over time, and what do they evolve to over time? And really what they've identified is sort of 4 groups of early onset, 2 groups of early onset asthma, and 2 groups of sort of adult onset asthma. And you can appreciate they all have some slightly different characteristics. These early onset groups tend to have allergy. There can be some reversibility, especially in this group, not as much in this group. In the adult onset, also severe, less allergic, fixed airflow, nasal polyps and sinus disease, really important. And in the second group of adult onset, they have moderate to severe, less allergic, reversible airflow. And the reason these are important is this can potentially guide therapy. And the feeling is that perhaps these early onset groups have more of an IL-13 driven disease, and these adult onset have more of an IL-5 driven disease. And that's going to be relevant when I tell you about some treatments we have available. So I want to just give a shout out about the nice work that this group is doing. All right, so when you think about evaluating that patient, first you want to figure out, do they have asthma? So that's important, right? So you want to confirm the diagnosis. take a history and physical, and if you can, try to do lung function testing. That's something from a general internal medicine perspective that doesn't always happen in the primary care setting. I'm seeing it more and more now, so that's great. I think it's really important to get lung function testing like we showed with our patients. And then, of course, address medication adherence. Those are key. And then what is contributing to asthma? There's a whole host of comorbid conditions that can make asthma worse, including allergy, certainly sinus disease, reflux, obstructive sleep apnea, obesity, depression, and in some cases vocal cord dysfunction, which is where the upper airway actually misbehaves and the vocal cords move in with inspiration instead of out. So how do you figure that out? Well, if the patient isn't responding well to traditional asthma medications, meaning especially an inhaled steroid, long-acting beta agonist, that might be a time you might consider referring to your friendly pulmonologist or allergist because they can dissect some of these issues as well, especially the vocal cord dysfunction. Certainly, if patients have evidence of sinus disease, rhinitis, you'd want to treat that. Reflux, you want to treat that as well. Certainly have them evaluated for obstructive sleep apnea. And then if you've decided that this is severe asthma, so we tend to do more testing at this point. We tend to do full pulmonary function tests. We might do a methacholine challenge and look at the vocal cords to rule out vocal cord dysfunction. We're going to look at exhaled nitric oxide. We're going to bring our biomarkers in, and I'll talk about those in a minute. And we might decide to do imaging. So when you get to this particular phase, this is where it might be good to get help from your specialists. And that way they can help you sort out what the best treatments might be for your patients in the biologic space, because that's really, at this point, specialists are using them certainly more than our primary care colleagues. So back to the comorbid conditions, our patient had evidence of sinusitis and rhinitis, and she had nasal polyps as well. And these are just listing again obstructive sleep apnea, vocal cord dysfunction. Reflux can be acid or non-acid. There's a lot of interesting data now on non-acid reflux that I think is also important. It can come all the way up and cause upper airway dysfunction, obesity, steroid insensitivity. So what you find is if you treat these comorbid conditions, you will very well find that your patient with asthma will require less medication for their asthma. So that's an important first step, is to go through this list in your mind. And then, of course, others would be looking at environmental exposures, ongoing smoking. Is there evidence of COPD? There's a lot of asthma COPD overlap that's out there these days, and how do you define that? And that would be the alternative diagnosis often is COPD, or it might be sarcoid, it might be bronchiectasis. There's certainly other things that look like asthma that may not be. Anxiety and depression are important, non-adherence, and then, of course, medications, aspirin being one we've already talked about, non-steroidals. I think we have an understanding, certainly that beta blockers can actually make asthma worse, and then ACE inhibitors can cause that bradykinin-induced cough. So what can we do in the clinic to figure out what kind of asthma our patients have? Well, we have some biomarkers available to us. We certainly need more. I don't think we're quite there with all the tools that we need. In a perfect world, I'd love to say that looking at sputum eosinophils is the way to go, because I actually am a fan of what that shows, and there's been some great work coming out of this institution looking at that. Unfortunately, it's not the best clinically available test. That's the downside. It does give you a window into the airway. You can often avoid bronchoscopy by looking at sputum eos, but that's not to be, at least in 2019. However, exhaled nitric oxide is a good biomarker. Does anyone, I know that certainly some of the pulmonologists use exhaled NO. Does anyone else use, by show of hands, anyone use exhaled nitric oxide? Nobody? Well, it's a good thing I'm here talking to you about it. So what it is, it's something that we can measure in exhaled breath, and if it's elevated, it suggests above 20 parts per billion, it suggests that there's untreated inflammation that needs to be addressed, really of this type 2 variety. Often maybe an IL-13 driven inflammation is one of the hypotheses. We can look at blood eosinophils as well as a way of understanding what kind of asthma, and this is going to be very important if we're thinking about biologics. IgE is the antibody we associate with allergy, and I like to do some specific skin tests. There's either skin testing or you can do blood tests for allergen-specific IgE, and that can give your patient a nice view of what are some of the allergens out there that are relevant to their disease and what can they do to avoid them. There's a couple that are under development, that urinary bromotyrosine, which is reflective of eosinophilic inflammation. That's under development by the Cleveland Clinic Group. and we're going to be looking at that in PRECISE. Club cell secretory protein 16, I'll show you a little bit of data on that, is in development. And eosinophil peroxidase is a product produced by activated eosinophils, also under development as a biomarker. So these are some data looking at EPX out of the Mayo Clinic Scottsdale. They've been moving this forward. And basically what these data show is you can measure EPX by nasal and throat swab, really easy. And these data look at the comparison of EPX in nasal and pharyngeal swab to sputum eosinophils and blood. And there's actually a very nice correlation. So they're developing this as a potential point-of-care biomarker that we can use in the clinic and get a sense right there whether or not patients have a lot of eosinophils. And I think that would be incredibly valuable because if you send off a CBC, you have to wait for it to get back, and it's usually later. It'd be nice to know while they're in clinic what their eosinophil status is. CC16 is club cell secretory protein. It's produced by the club cells in the lung, and it has possible protective effects from exposures, certainly in the asthma and COPD space, probably some host defense properties, but we're not entirely sure of its mechanism of action. We know that you can measure it in blood, and the serum levels are substantially reduced in smokers. And there have been some interesting cross-sectional associations with asthma and COPD, and it's being investigated now in longitudinal studies, certainly at our place at the University of Arizona. What these data show, this is by Stefano Guerra at our place and Fernando Martinez. They showed that if you look, that Arizona has a wonderful longitudinal cohort that has been followed since the 1970s. So these were children recruited in the 70s and 80s, and now they're adults. And what they showed is that serum levels of CC16 at age 6 predicts lung function in adulthood, and that lower levels predict lower lung function. And that could be asthma or COPD or neither, depending on other aspects of the history. If allergy is present, potentially going down the asthma route. If patients smoke, they may develop COPD. So this is very interesting in that I think it could be a very important biomarker. And with the SARP group and with Jean Bleeker and Julie Ledford and others at our place, and including folks here at Wake Forest, we looked at airway epithelial cell CC16 gene expression and asthma outcomes. So there's a particular SNP that results in lower serum levels of CC16. But this is actually looking at airway epithelial cell RNA. So these are from bronchoscopy studies done in the SUB program. And so what was very remarkable about these data is usually when you look at a single SNP, you may not see really strong associations with clinical parameters because it's just one SNP of many, and obviously asthma is a very complex polygenic disease. But in this case, low levels of CC16 actually correlated with whether a patient had asthma and whether a patient had severe asthma. So the lower the levels, the more likely the patient was to have severe asthma. Also, low levels of CC16 were correlated with lower lung function, as well as emergency department visits and oral steroid use. So we found these data extremely powerful, that one SNP could really correlate very strongly with very important outcomes we consider in asthma. So this could end up being a very interesting biomarker down the road. So how do we put this together? I know this is a complicated slide. So I think when you're seeing a patient with asthma, you feel like you feel good about the diagnosis, they're on treatment. How are they doing with their asthma control? Do they have a lot of symptoms? Do they need prednisone? So basically, you want to first decide, is the asthma uncontrolled despite stepping up to high-dose inhaled steroid and long-acting beta agonist? And so therefore, and the ways to do that is you can look at symptom scores. We use the asthma control test in our clinic that helps us decide on how much symptom burden patients have, how much are they using their albuterol, do they wake up at night with their asthma, do they feel short of breath, those types of symptoms, and how often. Have they required prednisone? Have they been to the emergency department? And how many times per year? So in fact, if none of those are present and the patient's controlled, then you just want to do close follow-up and actually reduce treatment, maybe step down treatment over time. There's a lot of situations where patients are left on high-dose inhaled steroids and long-acting beta agonists when they don't necessarily need them. So that's an important caveat to suggest also. And in fact, you want to step those patients down because these medications have side effects, especially high-dose inhaled steroids. So if they're doing well, absolutely step them down. If they do have some symptoms suggesting they're not well controlled, you may want to consider other entities. Tiotropium or Spiriva is a long-acting muscarinic antagonist, and you can add that as a bronchodilator. I'm sure many of you have heard of Montelukast, singular. You can add that in, especially in the setting of allergy. Theophylline is on this slide just because there are patients that are still taking theophylline even today. I have a few that do very well with it, despite, even though they come and see me and I say, oh, we've got so many great options now, you don't need theophylline anymore. And so we stop it, and a few days later they exacerbate. So I stand corrected. So I do think there's still a small place for theophylline in our armamentarium. There have been some really nice work, certainly by Peter Gibson in Australia, on use of macrolides in asthma, i.e. azithromycin, and it has benefits in eosinophilic and non-eosinophilic asthma, so that may be an option. So and then you might even need a short course of oral steroids. Clearly, we want to avoid as much exposure to oral steroids as possible, but on the other hand, sometimes you will need it to control symptoms. So if you're doing these things and patients are still symptomatic, this is where you might consider a biologic, and we bring out the biomarkers if they're not already measured and think about biologics. So let's talk about that. So this is just a slide showing you the action in the type 2 asthma space. This is the allergic asthma space. So there's lots of good stuff going on. Excuse me. Omalizumab, or Xolair, has been around for a while. I'm going to grab a little drink here. Okay. We have inhibitors to certain cytokines that we think are relevant in this type of asthma, interleukin 4, 5, and 13. We have a number under development. TSLP and IL-33 are produced by the airway epithelium, and we have antagonists that are under study right now. And anti-CRTH2 is also in phase 3 trials. In our PRECISE network, we're going to be looking at a JAK-STAT inhibitor, and I'll tell you about that for type 2 asthma. And there may be even a role for bacterial products, and I'll talk about that in just a minute. So the reason I wanted to show you this is there's a very crowded space in this type 2 asthma. So let's talk a bit about what we've got. So maybe some of you have heard of Xolair or omalizumab. It inhibits IgE, and it's been around since the early 2000s. And really for patients who have a very prominent allergic component to their asthma, those are the folks that that aren't doing well on high-dose inhaled steroids and a long-acting beta agonist. Those would be the people we might consider for Xolair. And this is an injection that the patients receive every 2 or 4 weeks, and it's really based on their IgE level and their weight. So that's how we decide. There is a study, there has been one study, thankfully, looking at which patients are responders to Xolair. And if patients have a slightly elevated exhaled nitric oxide, greater than 19.5 parts per billion, or increased peripheral eosinophils greater than 260 have been shown to respond to Xolair in the setting of allergy. Periostin is another biomarker that we have been looking at in asthma that really hasn't made it to prime time, so I'm not going to spend a lot of time talking about that today. Now, we also have IL-5 inhibitors, and IL-5 is a cytokine that is known to increase eosinophil survival. So if you can take IL-5 out of the mix, you can reduce those eosinophils and improve asthma. And in fact, we have 3 to choose from, and really in those patients who have very high peripheral eosinophils, greater than 300 is where you see the best data, in my opinion. And so especially in those patients who are on chronic oral steroids, if you have patients like that you follow, that's a good time to refer them to your pulmonologist or allergist, because the biologics have some very nice steroid-sparing properties, and it'd be great to have them off their prednisone, because we don't like patients on long-term prednisone. And these are the 3, just so you've heard the names. I don't expect you to remember. There's a lot of MABs. So there's mepolizumab or Nucala, reslizumab, which is an IV form, Sincair, and benralizumab Fasenra, and that's the receptor antagonist. Just so you've heard them. I don't expect you to necessarily remember all of this, but I just wanted to be sure you know they exist and that there are options for those patients that are having difficulty after guideline-based therapy has sort of ended. This is the most recently approved biologic, dupilumab or Dupixent, and it's interesting because it inhibits the IL-4 receptor, so it gets IL-4 and 13. And why does that matter? Well, IL-4 is a very important cytokine with regards to allergy, IgE production, and IL-13 has a lot of important effects on the airway in terms of mucus production, smooth muscle effects, increasing contractility, and airway collagen production. So getting both of those cytokines is actually a very good thing. And again, the data seem more compelling in those patients who have elevated eosinophils. But I'll tell you, anecdotally, I've got patients who don't have high eosinophils, and they have low nitric oxide levels that are doing well on Dupixent. I was a little surprised because the data wouldn't necessarily suggest that's true, but the big responders are folks who have elevated exhaled nitric oxide above 20, really in the 30 to 40 range, and high eosinophils. They do the best. And this is an injection that we actually give at home. So patients give themselves their own injection, which was new to us in the field. We weren't sure how that was going to work, but it's actually worked quite well. I mean, many patients already give themselves injections for other reasons, and so just with some teaching, it's actually worked out really nicely. It's really convenient. For the non-T2 space, we don't have as many things to offer. I had mentioned tiotropium and macrolides. Bronchial thermoplasty is a little bit controversial. This is a procedure that we do with a bronchoscope where we actually reduce smooth muscle mass by applying radiofrequency heat to the airway. I know that sounds a little unusual. It is. That has been approved, although it's difficult to get covered by insurance because it's not clear who the best responders are to this, and you need your friendly pulmonologist, bronchoscopist, usually your interventional pulmonary person, to do that procedure. So just to show you, this is the non-T2 space. You'll see it's not as crowded as the T2 space, and so that's important, just to show you that I think this is a real unmet need in our field. All right, so the very last few minutes, I just wanted to talk a bit about trying to put all of these concepts of precision medicine, how can we study this and really move precision medicine forward in asthma? And one of the ways we hope to do that is through this PRECISE network. And it was formed in 2017, really to conduct innovative phase 2 proof of concept studies in biomarker-defined adults and adolescents with severe asthma. And there's 10 clinical centers or partnerships, and I'll show you who they are. And so we are together with you all, which is very exciting. And so that's why this is right here, because it's spanning both. So we have an Arizona Wake Forest partnership, which I'm very proud of. It's great to work with this group. And you can see the other partnerships are all scattered all over the country. So the goals are really to identify novel therapies beyond the biologics that I showed you in these biomarker-defined subgroups, and then gain information about biomarkers. So those, the CC16 I talked about, the urinary bromotyrosine and the EPX for sure are being validated in PRECISE. So one of its roles is really to move the biomarker field forward as well. So that's exciting because we need those tools. So these are the interventions that we're thinking of, and these are very different than what I've been talking to you about. So I mentioned that one type of asthma in obesity may have an IL-6 component, and so we're going to be looking at an anti-IL-6, really for patients who have high IL-6 levels. Imatinib is a c-KIT inhibitor to look at folks who have low eosinophil counts, and this last column is really to look at the prevalence of the particular phenotype in the Severe Asthma Research Program database. And that's really been helpful to PRECISE so we can better understand how many of these patients are out there when we go to recruit them. A JAK-STAT inhibitor, we are recruiting patients who have high eosinophils or high levels of exhaled nitric oxide. VitaFlow is a food additive, and it actually has effects on mitochondrial function, can affect T-cell function, and we're looking at patients who have slightly elevated exhaled nitric oxide levels. Bronchovoxome is a bacterial lysate of dried bacteria, gram-positive bacteria, that's actually ingested. And there have been it's been approved in Europe for 20 years to decrease colds, the frequency of upper respiratory infections. Now there's some very interesting data on how it may reduce wheezing episodes. And there is a study going on in children from age 6 months to 2 years to determine if bronchovoxome given to kids who are at risk for developing asthma decreases the presentation of asthma by altering the microbiome. So very exciting. So we're going to try it in adults. Cavasonstat is a GSNO inhibitor. It has effects on the beta-2 receptor. And we're going to be looking at genotype-specific groups there. So very interesting, different therapies, we think. This took us a long time to come up with this list. But I think if any of these look positive, then of course they'll need to be studied more thoroughly in a phase 3. But I think what's the most innovative about PRECISE is this platform design. So it's not the basic randomized clinical trial with one intervention versus placebo. A patient will come into PRECISE and have the ability to have up to 3 different treatments. And this study will offer the 6 interventions that I mentioned. And so the idea is a patient, when they come into the study, they're phenotyped with all those biomarkers I told you to figure out what kind of asthma they have and which one of these interventions would seem like the best fit. So then they'll go into that intervention. But similarly, there'll be a group of patients who maybe don't have those characteristics will also be studied. They'll go through 4 months of this intervention, and we're going to be looking at outcomes having to do with lung function, exacerbations, and symptoms. So it's a multifaceted outcome. And in fact, as the patients are entering the study, more and more data are being generated as to who responds and who doesn't, and what are the characteristics driving the response. And then as more patients come in, as the study continues, that information will be used to further hone where these patients should go. So it's very interesting from it, and that's called an adaptive design. It has been used in the oncology world for a long time. This is really the first movement in respiratory. And so therefore, the design includes testing. The good news, the design also includes testing for futility. So if it looks like after a certain number of patients have come through that any of these interventions are not working, they'll be removed and new ones will come in. So that, again, gives patients more opportunity. And they don't necessarily they have to get placebo. They will have about a 2/3 chance of placebo. And so this is the overall design. So they'll come in, they'll be phenotyped, they'll move into an intervention for 4 months with a 2-month washout, and then they'll be eligible for the next intervention. So they can get up to 3 different interventions. Most likely one of those will be placebo, for sure. And they might end up usually with 1 out of 3 is generally the odds. So from a patient perspective, I think it's really interesting in that they'll have an opportunity to have more than one treatment in a study. And the idea is as the study proceeds, using machine learning and artificial intelligence, we can actually employ and do a better job at randomizing as the study proceeds. And that's this adaptive design. And then futility analysis I mentioned. There's also a precision medicine analysis to identify those target subgroups who are the best responders to specific interventions, and then sample size adaptations will be adjusted as the study continues. And then the final analysis is really about looking at lung function, symptoms, and exacerbations are really the outcome. And so I'm excited about this. We're going to start recruiting. Technically, November 1 is what we're told. If we're ready, we're doing a lot of coordinator training right now and screening of patients. And so if you have patients with severe asthma, you're going to want to make sure your wonderful group here at Wake Forest knows about them, because I think this is a great opportunity for patients to really to be able to receive other interventions. Because as I mentioned, our biologics they've definitely made inroads in treating asthma, the ones I described, but patients, despite our best efforts, are still symptomatic even with biologics. So the idea is the goal is to phenotype-directed add-on therapy. The challenges are phenotyping and biomarkers with a growing menu of immunomodulators that are expensive. And the key is to identify who will respond to specific treatments so you can give the right drug to the right patient. So hopefully you will agree that our understanding of the biology of asthma has improved dramatically. It's certainly a complex entity with perturbations in airway structure, as I mentioned, intersecting with early life events, genetics, and comorbid conditions. I think an understanding of the heterogeneity of asthma has really moved us forward and resulting in the multiple phenoendotypes that I described today, and allowing us to personalize therapy in ways we haven't been able to do before. I think there's still some work to do, but we've come a long way since the days of inhaled steroids and prednisone. So I'm very excited about that. And thank you for your attention.
All right. Well, hold on one second. Thank you all. Dr. Kraft, thank you so much for being here for such an informative, engaging talk on this topic of precision medicine for asthma. I want to encourage all of y'all, before we open it up for questions, please take time to fill out the evaluation form. They're on the table there. There's some in the seats, and you can leave those on the table out there. And with that, I'm going to open it up for some questions if you're willing to take a few.
Yeah, absolutely. We got a few.
You can screen.
Oh, there it is. There you go. So, Monica, that was absolutely fantastic talk. Just the complexity of asthma and the pathways that are involved. I mean, it was really eye-opening. You know, in terms of the data you showed on SARP with regard to the prevalence of the different markers, it looks like there's, tremendous overlap, between the prevalence of the markers, and that, it may be not ideal, that there's not one ideal treatment, for every patient. I was wondering, though, if you would comment on where you see over the next, several years, kind of routine phenotypic testing or, genetic testing, and if there's any, gene panels that are available now that are of any, value clinically.
Sure, that's a great question. So you're right, it is complex, and I think the slide showing that multiple endotypes can drive specific phenotypes really, I think, brings that point home. I think the cluster analyses, in general, they are relatively stable, but they can evolve as well. So it's a moving target. So the big question is really about combinations of treatments and thinking about different pathways. So there's the adaptive, adaptive response, adaptive inflammation, which are the biologics, really focusing on that. And then, as I mentioned earlier in the talk, there's the whole innate immune side, of which we have very few interventions on that side of the coin. So my thought is, as things move forward, certainly I would wonder about combination of innate and adaptive immune modulators, really, in these patients, would be one path. I think our biomarkers, as you saw, we were developing a few more, which is fantastic. I think Precise is going to let us do that. So I think we'll have more at our disposal in the clinic. I think urinary bromotyrosine could be a really interesting point of care, EPX. So we have more at our disposal right there to figure out what kind of asthma. Genomic-wise, I mean, this group here in Wake Forest has done a lot of really important work in the genomics of asthma. And I think that the question will be, and actually I'd love to hear some perspectives here from Dr. Ortega on this, is at what time will it become a clinically useful entity? And I think when especially looking at the beta-2 receptor, I think we're getting closer to really defining that in those rare variants that you talked about in Arizona a few weeks ago. So I think we're getting closer with regards to genetic panels to look at specific, certainly the CC16 expression that I mentioned, that would be an important one. There's certainly a lot going on in the rare variant world. So I think we're getting closer to these genetic panels, and that's going to be another choice for us.
Thank you, Monica. That was great. What's the frequency of your SPA genetic defect or alteration? I want to know whether I should invest in your company or not.
Okay.
What the market is.
It's the SNP of SPA2 at position 223. It's about 10% across the board, but in African Americans it seems to be higher. African Americans with asthma, it's about 30% is what we think, and so it's reasonably prevalent. Right. So that's the thinking.
So I'll make a genetic comment to address what you just mentioned, and then I'll ask a question about the surfactant protein A. So GWASs to date have identified probably nearly 100 loci that associate with asthma, and these GWASs span populations like SARP and other well-characterized NIH cohorts, but also actually involve large electronic medical record eMERGE, did a very large GWAS and found more loci. Those give us information on risk, but the variants that contribute to disease severity, exacerbations, drug response, those studies are harder to do. Mm-hmm. And I think that as we get larger, good electronic medical record data and we compile good clinical trials data, we can start doing that. For example, we just got published last week in JACI an analysis of African ancestry, European ancestry, and found that over 200 patient days of follow-up in these clinical trials that African ancestry associates with exacerbations. And what we think there is that there's an interplay between genetic variation and environment, social, economic factors that are contributing, and work is ongoing to figure out why that is. And rare variants, we're learning more and more about rare variants. We, this week, got a paper accepted in the Blue Journal on alpha-1 antitrypsin, the alpha-1 antitrypsin work that we're doing with rare variants. It's no longer a rare cause of respiratory disease because there's so many rare variants that altogether contribute to risk. So the library is rapidly growing, but I think the most useful risk panels are going to be those that are the genetic variants that influence drug response and disease progression and severity.
Right.
So So that being said, so the surfactant protein pathway is really interesting, and I know before we've looked at this, and I wonder if it's been looked at with TopMed sequencing data, because it's a pretty rich locus. And one of the things that strikes me about the surfactant proteins is that it has a very strong effect on the risk for pulmonary fibrosis.
Mm-hmm. Okay.
So I guess what I'm wondering with Julie Letford's work, which is fantastic work. I mean, 2 R01s just recently. I mean, Julie's a rock star over there in Arizona. But have you guys looked at how this pathway could influence the fixed airflow obstruction, airway remodeling aspects of asthma?
Not as much. We're focused mainly on mucin and eosinophils, as I mentioned, for more acute readouts, just to make sure that this, we looked at the full length and the peptide. We have done some work in the past, actually looking at interaction with fibroblasts, collagen production, and there seems to be a signal there. So that's sort of a whole other area. And what we're moving to now is some mass spec studies where we really want to know exactly, because we have an idea of which receptors SPA is binding to, because there are a number. It's a very sticky protein. So the question is how relevant are the receptors that it's binding to, and which ones are driving this? And so some of them would be obvious if you're interested, we're interested in IL-13 and other ones. But we actually are identified a new receptor on the eosinophil called myAtom that may actually have some interesting effects on apoptosis that SPA is binding to. So we hope to find some novel receptors with that work.
Yeah, and I would definitely, I think, as we're learning, like what we did with the alpha-1 antitrypsin gene rare variants, which we're now looking at in asthma and in TopMed, perhaps going back and looking at these surfactant protein genes again, because now we have very nice rare variant analytical tools to see. You have one that has an allele frequency of 10%, but with TopMed sequencing, I mean, I know that for sure the surfactant protein A, B, C, those are very rich loci with variation to see.
That's a great suggestion.
Yeah, where we're going in terms of looking at novel, more individualized level variation.
Absolutely. Thank you. That's
great talk, though.
Great. Thank you.
There you go, Josh.
I don't know exactly. Thank you for talking about Kraft. I was wondering if anyone is using biologics, particularly directed on eosinophils for some off-label indication for acute eosinophilic pneumonia, particularly the subset of vaping induced.
Yeah, that's a good question. Sure. Well, certainly for allergic bronchopulmonary aspergillosis would be one area that and that's actually, the Xolair has been used for that. There's actually some work on maybe Dupixent being maybe a possibility for that. There's been a little bit of off-label use if we're able to get it approved for the eosinophilic pneumonias. There's also approval now for Dupixent's been approved for atopic dermatitis all along, and there's been a recent approval for nasal polyps as well. So those are already in the works. But I do think there's a little bit of this use. I wouldn't, in the vaping world, no, I would say nothing's really been done there yet. I mean, those cases are now coming to light. And not surprised, to be honest. There have been some really compelling animal data with regards to the effects of vaping on the lung. And so it doesn't surprise me that now we're seeing these cases. And I think the question is where these biologics would fit in and how to best use them. But to date, they haven't been used specifically for that. All right. Thank you very much.
Thank you.
Thank you so much. Yeah, just try it. That was excellent. Wow, cool.